So, Megan, really kind introduction. And I think we've got 10 different countries worth of people joining us. So that's exciting. And we look forward to your engagement. Now, Ben and I have both been in Gaza quite recently. And we have been looking at this issue of NCDs and working very closely with Nahala. So we're delighted today to come together and give you a feel of what we've been finding out on the ground, what we've been presenting, and to get a discussion going really about where this goes to from here. So I'm going to set the scene by giving an overview and looking a little bit at medicines access and some of the issues relating to palliative care. And then Ben's going to come and add to that, particularly with looking at nephrology, which is such an important area, and we don't often talk about that at these meetings. But I wanted to start by just paying tribute to our colleagues in Gaza. The pictures here you can see on the right are Gaza as it is now, and the top one is the destruction of one of the universities. You'll have seen the pictures on the screen. So as we start, and we're not just looking at Gaza, we're looking at humanitarian settings, but I want just to pay tribute to our colleagues in Gaza who are operating under the most incredibly difficult circumstances, who are operating with almost no health facilities now, with borderline or actual starvation, with detention, and with the threat of more invasions, and particularly a situation where healthcare has become a target. And these are three of our colleagues. The one on the right on my screen, Dr. Hama Malo, was known to Ben and I. And in fact, is how we met and started to work together, because he was a very dear colleague who was killed, a nephrologist in Gaza. You can see the head of medicine, Dr. Rafat Lubad, and our dean of the medical school previous team, Omar Farwana, just three of our colleagues who have been killed. And I want to just take you with me as if you were coming into Gaza. So when you get to Rafah, the first thing you see is this endless queue of aid trying to get in. Then you see overflowing cemeteries. And of course, this is somewhere where you can build a cemetery. Other places, it's just mass graves. Kids outside the UN building, burnt out shells, people trying to live with dignity, and even on the edge of the sea as they're being pushed that way, and the smell of sewage is overwhelming. Accessing water, I heard today the temperatures are very, very high and people are really struggling. And healthcare, again, you can see here an ambulance under attack. So this is the context, not just here. We could show pictures from Ukraine, we could show pictures from Yemen, from Afghanistan, and from other places that some of you will know well, but where we're in an acute emergency situation. In Gaza, of course, that acute emergency involves people being trapped, so they're unable to move and therefore can't flee and are having to endure whatever comes their way. And that's a pretty terrifying experience. I'm going to ask you just to, as we watch this 1 minute, just to reflect. And if you're somebody who prays, to pray, just to think about trying to do healthcare in this kind of environment. That was taken with my phone, just leaning out of the car on a street called Saladin Street, which links the north and the south of Gaza. It's hard to watch, and it's unimaginable to be there. So that really is why this first slide has the very first thing, seeing staff support. What we were seeing on the ground, and this is reflected in many settings, is the staff themselves need help. In Gaza, they are displaced 5-6 times. They're looking for places of safety for their family. They have no salaries for 6 months, and yet food prices have escalated to 5, 10, or even more times it was before. And they need us to show genuine solidarity and support for them and genuine partnership. We've talked before at these webinars about the need to address some of these power differentials, that it's not about us going to help them, but actually together coming in partnership in a dignified and respectful way to offer what care we can. And so there needs to be a building of local capacity, wherever that is, and some ownership from local capacity, the leaders and those on the ground. But there is a real crisis across the world, and it's been highlighted in Gaza, and that is in the emergency response. NCDs, which includes the areas we're talking about today, are really not represented. I would actually say almost 99% not represented. And that also then leads into other things like equipment and medicines and how it's needed. So there's a gap. We've done a really good job, I think, of beginning to integrate in the preparation phase and in the response phase, the sort of rebuilding phase, but not in the emergency phase. The other thing that's striking is that multimorbidity is the norm, and then you've got a chronic illness, maybe more than one, and then you've got an acute illness, and then you have an injury. So these vertical streaming and planning is not helpful. There's often little access to imaging and blood tests, blood products, etc., and that's the case here, no histopathology at all. And all medicines are in short supply. And interestingly, then the priorities may change. So it may be that long-acting medicines are much more appropriate, or things that people don't have to come back to health centre so often. So a 3-month prescription. We also saw huge problems with basic things like skin care. And we saw patients dying of sepsis because of the lack of effective ways to protect the skins when there's no electricity for the usual fancy beds. And the need for psychological first aid and care in how you go in as a team to work with people. Let me introduce you to Mohammed. He was a civil engineer by trade and was diagnosed with follicular lymphoma 4 months ago. He's in Al Najjar Hospital. Now, that's a hospital that was built with 60 beds, small hospital in Rafah, and it now has 700 plus patients every day. He has been referred for 4 months, and interestingly, his sister and his father have both been referred, one with myeloma and one with a flare-up of her really quite serious inflammatory arthritis. So a picture of chronic illness in one family. His disease is now extensive. He has recurrent chylous effusions, but I'm delighted to say that this gentleman actually has good palliative care from Dr. Amjad, who's just standing in behind some of the people that we've trained. If you want to know what's on his t-shirt, it says nothing is stronger than love except for an Apache helicopter with rockets. This young man had a very accepting and he was a very courageous gentleman who knew what was happening, was talking to us about it, was hoping for a referral out for treatment, but was also very appreciative of the care that he'd got. This is the small oncology team that is there in Rafah. There's a few others scattered, and that's another challenge. People are scattered, and new cancer diagnoses are very difficult to make. There's a mistake on this, I should say EMRO, but let's zone out a bit from Gaza to look and see what's happening globally with this issue. So the EMRO has been leading the way with this framework document that was launched last year. And also there's been a high-level technical meeting, very important meeting in Copenhagen recently, and some of us were there representing. And I think there is now really very significant buy-in and acceptance from the international community that this is missing, and that there might even be more deaths from chronic illness than there are from trauma. Certainly there will be a huge number, particularly when you add in infectious diseases such as cholera and the other outbreaks we see in emergency settings. Hepatitis is very common as pneumonia, and this is repeated against through all emergency settings. I mentioned the 3 phases. I think we have done relatively well to integrate in the preparation and recovery stage, but not in the emergency response stage. And that's why that's the topic of today. But a lot of the things that happen in the response stage only can happen if the preparation stage is done well. I'll mention some of those in a moment. Palliative care is particularly challenging because it cuts across all of them, and they have some particularly difficult issues around medicines access, although I'm sure Ben will share challenges in other areas in medicines access as well. When we look at what we need to do, well, we've got our palliative care house. We're used to this. It's the same overall picture, but then applying it into a situation where the health system may be completely destroyed, or it may be only deliverable in field hospital settings, or it's a displaced population. So I just look at access to medicines for a moment. The policy issues here are even more complicated because you may have to pass through another country to get your medications. So there may be 3 layers of policy: importing to one country, exporting from that country, importing into the country that's experiencing the emergency. My understanding is in recent days, it's only been successful in Ukraine and South Sudan because there were some systems in place beforehand, or the governments were still functional. But that doesn't mean we shouldn't try. So get our policies done as well as we can before an emergency, and remember fragile states and focus on that. The procurement, as I said, is very complicated. I will show you on the next slide a system of kits that are there for WHO, and there sometimes are one-off supplies. For example, the day I was there in Gaza, they had got supplies via UNICEF, and they were delivered to that small clinic where we had capacity from trained colleagues. Standard protocols really helpful, because in an emergency setting when all sorts of people are coming in, having agreed protocols is helpful. And I'll show you the ones that we re-released in Gaza. Here they are. Now, in fact, we had worked on these already. So all we did was change 1 or 2 lines. These were owned by Gaza, which I think is really important. And they clearly put the pharmacist in a significant role. Rather than a few fentanyl patches arriving here and an unknown opiate arriving here, we wrote it very simply so that then the pharmacist could advise what's there in the stores. And one of the sad things in Gaza and other places is the stores get regularly destroyed as displacement happens. So with this rapidly moving population and the destruction of the health system, it means that even the stores that are there get destroyed. The kits is complicated and it affects the whole of NCDs. There is an NCD kit. This has been an amazing step forward by WHO. It's meant to be for 10,000 people, mostly in a primary care setting, like getting into a rural setting in where there's been an earthquake or a displaced population. It doesn't have controlled medicines, but there are 3 other kits with controlled medicines. That's the CR module. The challenge I've mentioned is getting those modules in. So in this circumstance, most of the medicines get in through the normal channel, and then the controlled module can be separately managed for procurement, and you can order more than one. But when we've been looking into this and working hard with Nahala and others, for opiates, there's only really enough for 1 or 2 patients per month, and yet it's for 10,000 people. So there's a lot of work to be done to look at the content of these kits, but there is some precedent there that we can work on. Mass casualty events. Internal medicine, palliative care, we need also to be aware of what's happening in the mass casualty. We've seen this slide before from Nepal, showing an old-fashioned way of mass casualty events. But I'm delighted to show you this today. This is from the WHO Academy. It's a really helpful way of looking at mass casualty, where the blue zone, which is where most of the patients with multimorbidity and those with who are not going to survive because of the extent of their injury or the lack of access to treatment, are managed together alongside, but in a separate zone from the yellow and the red, the more active zones. This is vital for several reasons. It means they're active care, which is hugely important. It also means that if the situation changes or the condition changes, they can move. It also means that if you have, for example, a new line to get an IV or whatever, it's much more available. And this is a lot more dignity. But how do we train people against this? This is a great training module. I would say need to be more involved with our colleagues. This is an emergency unit. I think this is an excellent design, and it'd be great to see more cross NCD and palliative care training embedded in all first responders, because I think we need an awareness, particularly amongst our emergency colleagues. We did identify at some of these issues at our high-level meeting. My apologies, apologies. So I think I've said some of these things, integrated into the emergency response, including the content of emergency medical teams, mass casualty triage, medication supplies, and holistic support for patients and families, but also for staff. Review the emergency kits and look and see if we can get the right amounts in the right place with the right protocols. And in the phase 1, that means the preparedness phase, let's look and see if we can do more training. I also want to mention something in passing, and that is the Health and Peace initiatives from WHO. I think there's things we need to think about how we might contribute to those initiatives, and maybe that's a topic for a future event. I want to come back to our colleagues and the courage of our colleagues. This is from one of our pharmacists. Despite the pain, hope persists. How there can be hope in such circumstances is a tribute, I think, to the faith and humanity of our colleagues on the ground in their emergency settings, carrying on caring for patients, even when the situation is almost unbelievable. And then I want to, just before I finish my comments just now, there'll be time for questions. I want to just read a letter from a 6-year-old, because this is affecting all ages. And this 6-year-old is the grandson of a colleague of mine from Achley Hospital. And he wanted to write me a letter, and I'll read it to you. Hello, Dr. Mhoira. That's my Arabic name. I'm from Gaza. I had a life. I had a home. I had toys and everything. I was happy. Now I don't have friends because Israel killed them. My hope is burned when we were there. I can't sleep since this day, and every day I dream of fire and bomb. I want to live in peace and happiness. I want to play and go to school. I'm so sorry to say this to you and make you sad. I'm happy that you're here to help people. I hope next time everything will be okay when I see you, and this sticker is a gift from me to you. I love you. In this little excerpt is humanity, is the reality of the suffering, is the hope of a little child, and is his concern for me, that dignity. And these stickers, Gaza's famous for its asir faraula, for its strawberry juice at this time of year. So let's hold on to that humanity. And I want to read just a meditation that is written. This is a reply meditation between a professor of English in the UK, a professor of English in Gaza. They've been working together for many years, and they write these joint prayers. So let me just read this meditation, then we'll finish. Sud is the courage and steadfastness, a term that means a lot in Arabic and means a lot to Palestinians. Bless the helplessness, the utter helplessness, the unutterable agony of utter helplessness. Bless the endlessness of the helplessness that still resists death daily, even as the helpless are dying for want of help. And the reply from Gaza, bless the help that never ends and the endlessness of our friends. Bless those who defy despair by planting hope and the despair that ends with a strong rope. Bless those who pray for the end of war and those who keep trying to open for us the door. Those who keep praying for our kids and those who keep trying to make us well fed. Thank you, and I'll hand over to Ben.